Hello and welcome. My name is Chris Rowena, and I'm the lead communications analyst at HCAI Health Workforce. We're so glad you could join us today for the first in our series of Rural Health Transformation Program, or RHTP, listening sessions. Today's session is focused on technology innovation in rural health. Our aim is to hear directly from you, your needs, your challenges, and your ideas to ensure that California's planning for the RHTP reflects the realities of rural communities. Before we begin, a little bit of housekeeping. Just a few notes to help you get the most out of today's session. Number one, this platform is hosting on Zoom, and your controls are in the toolbar at the bottom of your screen. Number two, Q&A. We're using the Q&A feature for all comments and questions. Please type your input at any time. Questions will be moderated before they appear publicly. And number three, today's session is being recorded. The recording will be available on our website within 5 business days. A little bit about the session purpose and why we're here today. Number one, to provide a high-level overview of the program's goals and structure. Share early survey findings to show how your feedback is informing our approach. To listen to your thoughts, experiences, and ideas for a topic-specific deep dive. And HCAI's commitment today is we're here primarily to listen, not to present. Your feedback will influence how we design this initiative. This is the beginning of an ongoing conversation. And just a housekeeping reminder, please do use the Q&A feature to ask your questions or to submit any comments. And with that, it's my pleasure to introduce the Chief Medical Officer of HCAI, Lamena Tefera, who will provide opening remarks and the rest of our presentation.
Thank you, Chris. Good morning, everyone. Happy to review the program details today with you. The slide shows an overview of HR1, which provides $50 billion in funding. As described here, there are 3 permissible uses of the funds. You can look on the strategic goals to the right of the screen, and you'll see the options available to submitters. So of these options, we'll be looking at what is most strategically savvy for California to improve rural care in the proposal. Next slide, please. The funds will be distributed over a course of 5 years. The $50 billion the allocation is described by CMS in detail. Half of it will be distributed equally amongst the 50 states who submit a proposal and have it approved. The other half of the $50 billion will be determined on a case-by-case basis by CMS based on criteria set in the proposal. Note here that the distribution of funds is year to year through 2030, and also note here that for any given year, it's a fixed amount of funds that will be distributed, and there's also additional language from CMS regarding annual auditing of the use of the funds that's important to remember. Next slide, please. Touching on permissible use of the funds, the categories are listed on the left. And it is from these categories that submitters will need to choose what makes most sense for their state's application. As you can see today, this webinar is focused on technology and innovation, which is mentioned several times on the list of permissible use of funds, including item C, item F, and contributes to item I listed to the left. And these are areas where we hope you'll be contributing in our thinking about what we submit in our proposal. Next slide, please. So the Rural Health Transformation Program timeline briefly here. So the states are conducting surveys of all participating stakeholders up until the submission of the proposal. In California, this has been ongoing since even before the release of the proposal, anticipation of its release throughout September. The submission deadline is November 5th. Once submitted, there'll be a review period, and CMS has signaled that decisions will be made by the end of this year, December 31st. Awards and distribution of funds will start in 2026 in as yet to be determined timeline. Next slide, please. So far, and I emphasize the so far because it's ongoing, we've heard from over 350 stakeholders, many of which are clinicians and care providers across the state, including hospitals, federally qualified health centers, Indian health service sites, tribal health sites, mental health programs. We've also heard from non-clinician providers, including counties and departments within counties, affiliated cities and other government entities, academic medical centers, philanthropic organizations, and health plans. We've really tried to cast a wide net to make sure that we're hearing preferences from all across the state. Next slide, please. Focusing on today's stakeholder topic, technology and innovation. The desire is to equip our rural communities with the tools to deliver care more efficiently, securely, and equitably. Ideas that were included in the proposal and the application included remote care access, data sharing and interoperability, cybersecurity, and inclusion of or supporting the inclusion of emerging technologies in our care system. Next slide, please. In feedback from over 350 stakeholders that I mentioned previously, stakeholders noted that website portals with reminders, education resources, and scheduling assists are important. Stakeholders also noted the value of technologies that utilize text messaging to help patients remember their appointments are important. Applications are on smartphones to promote healthcare decisions and choices and adherence by patients was also brought up, as were the value of diagnostic aids for digital monitoring, remote monitoring, and home testing. Community resources and community kiosks to promote health and wellness were also noted. Next slide, please. This is kind of a big picture overview of what we've heard from our stakeholders. I'd like to emphasize the important areas that have been elevated by stakeholders and that we also think are important for our submission for this proposal. Elevating primary care, being thoughtful of promoting patient-facing technologies, utilizing and leveraging telehealth and electronic health record integration, thinking about broadband and connectivity and how it impacts subscribers' ability to use new technologies, promoting cybersecurity and IT support for facilities that need this type of assistance, and using data and analytics to make thoughtful and data data-informed decisions in patient care, but also strategic decisions for facilities and other entities in impacted areas. All these areas are under the large umbrella of technology innovation, and stakeholders gave us extensive feedback on ways for us to consider elevating these items in our proposal submission. Next slide, please. What we want to hear from you today is your thoughts on what collaborations could help your facility. For example, telehealth collaborations to increase specialty access where specialty access might not be available. We'd like to learn about engagements that can promote existing maternity care agreements or potentially help establish new maternity care agreements in areas where there are gaps in maternity care. We'd like to hear from you about your electronic health record. Which one do you use? How would you describe your ability to exchange health information with other facilities near and far? And what are your aspirations for your ability to engage in health insurance, health information exchange, and interoperability with other sites? We'd also like to know if you have existing preferred commercial carriers or unique commercial contracting relationships that can help promote your use of technologies at your particular sites and learn from those relationships that have been beneficial to your site and the communities that you care for. Next slide, please.
So we're gonna hold off. We'll hang out on that slide, the previous slide, so the questions stay up. Thank you, Dr. Tefera. And as we go into the Q&A session, we just thank you for joining us today. This really is the heart of today's conversation. Again, to participate, click on the Q&A button in the toolbar and type your question or your comment. And remember, this is a listening session. Our goal today is to gather your input. Some of the details of the program are still in development, so we may not have every answer yet. And I see my camera is not turning on. I apologize, for some reason my camera is not turning on, but I am here. There it goes. All right, so as we get some questions in, one of the things I want to mention and remind you is we are recording this session, and all of our sessions, we will have these posted on our website within 5 business days. And so we invite you to share this out with anybody who may have missed it. And just a reminder, we do have another session coming up at 2 p.m. today.
I can take the first question that I see popping up here. It reads, can we use artificial intelligence and technology to reduce administrative burden for providers? So I think at a high level, AI technologies are seen as a means to improve lots of processes of care across the healthcare ecosystem. The proposal itself will be focusing on advancing healthcare goals for rural communities, in as much as the use of an AI-based technology can increase efficiency, promote quality, and otherwise help the entity achieve those goals. There's certainly no reason not to include AI-related technologies in work to promote healthcare quality, access, promoting affordability, and care in those communities. Another question I see here, would simulation education for residency training fit here? So uh, we'll be having another stakeholder engagement regarding workforce initiatives. Many of our workforce initiatives will be focusing on promoting retention of clinicians in rural areas and also recruiting clinicians to rural areas. If there is an idea or concept that simulation related education can upskill trainees, whether it's physicians or other clinicians, to expand the scope of their practice or their ability to serve in a rural capacity to fill gaps that might exist because of a lack of access. Otherwise, it's certainly feasible that simulation education could help support that goal of increasing capacity and increasing scope of practice for different types of clinicians practicing in rural California. Next question. Could the funding for federally qualified healthcare centers to upgrade electronic health record systems help them move from a legacy system that will improve data collection, tracking, and reporting outcomes measure assessment be included? Again, related to the last answer, the proposal will be focused on goals of improving healthcare outcomes to rural communities. And in as much as a participating entity can make a rationale that healthcare outcomes can be and will be improved with a more functional electronic health record that utilizes interoperability and communication with other clinicians where patients in that entity may have been. That rationale can be a part of the proposal. That said, the proposal, the application from CMS has explicit guardrails about capital funding for facilities, including for purchasing new equipment. So it's an area that has some opportunity, but that opportunity will ultimately be determined by what CMS deems permissible. Next question. Can telehealth modalities be considered as part of the technology deployed under the grants? Yes, telehealth, as stakeholders on this call are aware, really exploded soon after the pandemic, and has been an important means to facilitate primary care, has been an important means to create opportunities to see specialists in a more timely manner. And as such that rural sites of care really struggle with sufficient access to specialty care, including behavioral health support. We do see telehealth and augmenting telehealth as a critical way to improve care overall in rural California. See, next question. Is it permissible for the state to partner with supporting technology solutions, or will those partnerships be at an individual facility or organizational level? The role of the Department of Healthcare Access and Information is to lead the submission of the proposal, and highlight the key needs of rural California to improve healthcare in those areas. It is so much that partnering with private firms can promote that application. Certainly, those partnerships are welcome. The CMS application encourages public-private partnerships and collaboration, and we think that's important for improving efficiencies and care, not just rural California, but across the state. Of course, the specific partnership and the extent of that partnership will, depend on the particular work stream. But the short answer is yes, it's possible, and it may be dependent on the facility. It certainly will be dependent on the type of action that is being promoted in the proposal. Let's see, I'm looking for the next question here. Let's see. Are there any plans to engage the coordinated entry exchange system? I'm not sure if I understand the reference to coordinated entry exchange system. If that's a reference to our data exchange framework, I'm happy to welcome Healthcare Access and Information leader for the data exchange framework to speak a little bit about opportunities to promote data exchange and interoperability in our submission.
Thanks.
Jacob available? Yeah, Jacob Parkinson, please go ahead.
Thanks, Dr. Tafaro. And happy to answer that one. So I think care coordination is critical for the data exchange framework, but we believe to be critical for our rural facilities, our rural organizations. So I think there is a real opportunity there for technology to be used to improve care coordination, both in terms of improving interoperability capabilities of these orgs, but also just looking at new technology that's used for referrals, for any number of these kind of care coordination activities between our rural hospitals and outpatient facilities. So there is plans, but I think that what we want to hear from you all is what do these rural facilities need in terms of care coordination? What are the needs here, and where might we start to employ our efforts?
Thank you, Jacob. I'm scrolling through questions here, and the questions are definitely piling up here, and trying to be fair in choosing them. There's a question here that's related regarding remote patient monitoring. Would you see funds for obtaining devices and training staff on remote patient monitoring as part of these rural health initiatives? So again, I think that the way to answer this question is to focus on the larger goal of enhancing patient care quality and addressing gaps in care in rural California. So an initiative locally, whether it's a public-private partnership or otherwise, that utilizes remote patient monitoring to improve the healthcare of the community, that identifies ways to increase efficiencies, possibly even be more affordable and cost savings. All of those can certainly be consistent with the goals of the program, and the application itself did call out a consideration of remote patient monitoring, and that's something that we're actively thinking about how best to how best to include the utilization of that technology and to promote it in the proposal. This is a high-level question about whether the grant program is limited to nonprofits or private firms. So the proposal is for states to advocate for the most effective ways to improve the health of their rural communities. The partnerships involved in those proposals is open, and depending on the goal of the particular proposal that's elevated, it's certainly possible there can be public-private partnerships. I think the main thing to remember is how are we working to elevate high quality care, elevate access where there are access challenges, promote efficiencies, promote safety in these rural communities. Moving on to another question. Will the Department of Healthcare Access Information be releasing the 3 areas of focus that will be submitted in its application? When might we expect that? So our department is continuing to work through the application and making sure that California will be submitting a robust application. The application is due to CMS, as previously stated, in early November, and that is when the details of the application will be made public. As we stated earlier and showed on the slide deck, it is an incredibly narrow window to stand up an application of this size. So we're being as thoughtful and methodical as we can, while also engaging our broad list of stakeholders across the state. But folks should expect to see the final results with the submission in early November. The next question is a data exchange framework related question that I'll read and await Jacob's answer. Is it possible to create one common electronic health record system for all providers for easier communication and documentation?
Yeah, I'm happy to take that one. I think it is, we don't see it as something, a feasible opportunity for us to promote a single system or move towards a single record system, just given the diversity across the state, the size of the state. But what we do believe is there is a lane to make sure that the systems can work with one another, that they are interoperable with one another, that we can communicate across those systems more easily. And so I think a goal as a result of this project would be to make sure that rural facilities have a system that can communicate in a way that they need to provide good quality patient care to their constituents.
Thank you, Jacob. Another question, is the state application only focused on physical health, or are you addressing behavioral health and/or addiction? So the application is focusing on both medical and elevating both medical and behavioral health. Proposals that improve medical health, can also integrate behavioral health enhancements. One of the tools that has been very helpful in increasing access to behavioral health services across the state has been telehealth, and we're hopeful that expanding telebehavioral health services is something that can achieve better behavioral health in rural California. And another interoperability related question. Can you please talk about the role of digital identity and interoperability in California? Do you want to take that one, Jacob?
Yeah, sure. Well, first off, on the digital identity piece, digital identity means many different things to many folks, but we believe that there are, in order for those systems to communicate, like we chatted about in the previous response, we believe there is a real need to make sure that when we look at the 40 million people across California, two systems can recognize the same person and can communicate about the same person effectively, both from a privacy and security standpoint, but also just from an ability to receive the records you need standpoint. So I think it's critical, in understanding what those digital identity problems are is a real need. In terms of the role interoperability plays, yeah, we believe it's highly important, not only in terms of what EHR you use, but what technology vendors you use, what health information organization vendors you use. And so EHR is certainly a portion of it, but interoperability is a much bigger slice that we need to consider.
The clarifying question here, can rural health transformation program funds be used to purchase a new EHR system? The application has strict guidelines about use of funds and grants for fixed facility investments. So it is unlikely that the fund would be able to support purchasing of whole new systems, depending on the goal of the facility and how enhancing, upgrading, perhaps increasing the capabilities of an existing electronic medical record fits into a larger strategy of enhancing the community's care. There are descriptions in the application that allow some amount of money to be spent on these types of upgrades. But again, that will be closely monitored by CMS. So it's an area that we'll be tracking to in the proposal. But as written, the proposal generally suggests there will be limited funds for direct funding of purchasing hardware. Another question here relates to what will the role be of community supports in the plans for rural health improvement. So as is noted by lots of clinical leaders managing care for communities, the patient's healthcare improves not only with the clinicians caring for them, but also the support services in their homes, in their communities, to make sure they can achieve their health goals. So community supports will be a vital part to integrate to make sure there's bi-directional communication with local clinics, the local hospital, to help promote the healthcare of patients and to establish continuing relationships. So the proposal, the application, excuse me, does call out the importance of community supports, and the submission will certainly address the importance of that in elevating primary care and chronic condition management. Next question relates to strategic management of the program. The funding appears to be one time. How will systems initiated under this funding be sustained after it is gone? So this question is something that we think about a lot. Besides it being one time, as noted in the slides today, there's an allocation that's divided equally amongst the states, and if approved, the states will receive the same amount, and there is another allocation that's based on criteria set by CMS. There's further year-to-year auditing of the use of those funds to make sure they're in line with CMS criteria. So it's important for us to think about using those funds in a way that will couple well with work that is ongoing to promote long-term health of rural California, and will augment systems that have an infrastructure to continue on despite the level of funding from the grant. So it's an open question of how much California will receive and how long California will receive those funds. But we are trying to be strategic in the inclusion of concepts in the proposal that will be agile and sustainable, even with fluctuating funding support. Question related to the application submission. Is there a healthcare access information list for businesses, especially small businesses, to get onto as part of the CMS submission? So the answer to that is not for the application, and no. We have requested stakeholder input. We conducted a statewide survey. Interested entities are still welcome to write us at the State Office of Rural Health and share ideas at our public email. But the submission is coming from the state, and will be highlighting goals and submitting ideas and concepts for the proposal from the state, and will not be including business names per se. There's a question here about which map of rural areas will be used to determine eligibility for the program funds. So the proposal the proposal will be responsive to the stated requirements for rurality in the application, and in subsequent CMS communications, they have defined criteria that meets their rural definition for the proposal, and we intend to follow that as as closely as possible to make sure that all of our eligible rural areas can receive funding. Another question about community health workers. Does community support cover services provided by community health workers? Again, the application called out the many benefits of integrating community health workers and navigators in rural healthcare systems. And our proposal seeks to be inclusive and certainly promote the use of these community supports to benefit the health of rural communities. What that looks like at the end will be determined by the particular local partnership. But certainly at a high level, we anticipate community health workers' participation being important to the submission. Another question, this is a high-level question related to data exchange. I'll read it and then ask Jacob to weigh in. How will the Department of Healthcare Access Information ensure interoperability and secure data exchange?
Yeah. So one thing that we do in the state, we have statute to create a data exchange framework. This means some organizations across the state are required to participate in data exchange and interoperability with one another. Now, the goal though is to make sure that all folks in the state, all organizations in the state who want or are required to participate can participate. They have the technology to participate. They have the workforce, the technology staff members they need to participate. And so I think a big part of this funding opportunity is to make sure that these facilities are equipped to participate in the data exchange framework and to share data with one another in a private and secure manner.
Thank you, Jacob. Another question regarding use of technologies. Let's see. Is the application focused on integration and team-based care that includes behavioral health, care coordination, care management, substance use services? So again, in the proposal that we'll be submitting, we certainly will be elevating the importance of robust primary care, a primary care that coordinates the care of patients both for their medical and behavioral health needs. And if their behavioral health needs includes substance use support, that coordination is also critical. There's abundant evidence that demonstrates that coordinated care both drives higher quality and also provides that care at a lower cost. So we think the ethos and kind of the principles of care coordination and care management are important to the proposal, and that's something that in partnership with the particular sites that we think will be important for the success of the program and elevating and improving rural health. Another technology and social services related question. Would you consider using technology to identify and close clinical gaps in care and social gaps in care as part of the funding? Would this be included under the allowable activity promoting evidence-based measurable interventions to improve prevention and chronic disease management? Again, to the extent that a technology, whether it's an application or utilization of artificial intelligence to identify high risk or in need subscribers in the community and to improve their care. That kind of use of technologies to help strategically support communities, I think is thoughtful and would be considered allowable under the list of allowable funding streams in the application. There's a question here related to single and small physician practices. Can funds be used to target single and small physician practices, outreach, and technical support? Many do not have robust electronic health records and staff to implement technology. This is a question we think about a lot, not just for this proposal, but really in our larger work to promote affordability and access in the state. It's vital that we support our small practices, especially since so many are in rural communities. It's also vital that we promote coordination. So we certainly envision collaboration between larger systems, larger communities of care, whether it's with telehealth or other resources. And to the extent that a physician practice wants to participate in a larger network or a regional collaborative of care for their community, it is feasible that practice could receive technical support, financial support to participate in that collaborative. Again, I think the way to view the avenues to receive funding from the grant is how does the specific entity contribute to the larger goal of improving healthcare in rural California. Once there's a clear path to how for example, physician practice will be able to contribute to that larger collaborative by joining it, then it would be eligible to receive support, from a grant working in that community. Would providing technical assistance to safety net providers about the use of technology be an allowable use of the funds? This is a relatively broad question. Again, the safety net and defining the safety net is certainly inclusive of rural California. There are safety net providers and facilities also in urban areas. The application is really focused on rural communities. So to the extent that participating collaborations will be providing technical assistance to clinicians and provider groups in rural communities, that technical assistance could certainly be a part allowable uses for the funds. Next question goes back to one of the technical items or the technology items listed as an allowable use. Cyber security is a broad term. Will the agency consider resources for work to improve security for providers to include medical device security, compliance monitoring, facility systems security, and email security? I can start with that and pass on to Jacob. I think most folks will have heard of some story in the news about a cybersecurity issue at a healthcare facility. It is unfortunately becoming common. It is important to support and elevate the cybersecurity capacity of our healthcare facilities. The application calls out supporting cybersecurity as a usable fund. The application also limits the use of funds for fixed facility costs. So there is a little bit of a challenge there in trying to identify, how much focus can be made or given to supporting entities that want to improve their cybersecurity. But we certainly agree in the principle that it's important to promote cybersecurity and that it's important to maintain the security of California's health information. Jacob, I'm not sure if you want to add anything else.
No, I think you covered it well. I mean, we care about interoperability, but we care about interoperability for a reason. Same thing with privacy and security. It needs to lead to a certain outcome, sustainable access at these rural facilities, ensuring that many of these rural folks can receive care in a way that they feel comfortable. So as long as we can tie it directly to an outcome that supports these rural health facilities long term, I think it's certainly a part of our priorities.
Thank you, Jacob. We're coming up on the hour. I think we may have time for one more question. Let's see. There is a question here about mobile health units. Could the fund support the purchase of a mobile health unit? And I see this theme has come up several times about what are the kind of the guardrails and limits of the funding. We as submitters have the same questions and have asked for clarification from CMS, and we're hopeful to be as inclusive and thoughtful in our proposal. Ultimately, it will be CMS that determines what is a reasonable use of the funds. Going back to my response to several other questions about the use of funding, if the particular action, in this case, purchase of a mobile health unit, promotes a larger community goal of increasing access, promoting access to specialty care or behavioral health, promoting connectivity or collaboration with a local healthcare system or other cooperative agreement, it's feasible that a mobile health unit could be a part of that participation, but ultimately those granular details will ultimately be determined by CMS, who will, approve or not approve those constraints. But in our proposal, we certainly think there's value in considering the benefits of bringing healthcare to patients in their communities, especially for patients with transportation issues and who are isolated for various reasons. So it's a thoughtful question. We're coming up on time. I'm not sure if we have some closing remarks from Chris and the team.
All right. Thank you, everyone, for your thoughtful participation today. And thank you, Dr. Tefera and Jacob, for your thoughtful answers. We have captured all of your questions today, even those that weren't answered live. If you do think of any additional questions or feedback later, please email us at calsor@hcai.ca.gov. That's calsorh@hcai.ca.gov. Your feedback is an essential part of shaping California's plan for the Rural Health Transformation Program. Before we go today, we would love to encourage you to visit some of HCAI's other resources. Please visit our website for resources and updates. You can also engage with us on our social media platforms. We are in a lot of places now online, and we would love for you to follow along and tag us with any great work that you're doing related to HCAI. We do ask that you would share all of this with your network. If there's somebody that wasn't here today that you know needs to be, we have 4 more sessions over the next few days, so please invite others, and we will have that second session today at 2 p.m. This does conclude session 1 for tech innovation for the RHTP listening sessions. Thank you again for joining us, and we look forward to continuing the conversation in the sessions ahead. Have a wonderful day.